Alright, so today we're going to be going over the nursing process theory by Ida Jean Orlando. My name is Kenzie Taylor, and I'm going to be your presenter today. So a little bit about Orlando's background. She was a first-generation American born in 1926. She received her nursing diploma from New York Medical College. She got her Bachelor of Science in Public Health from St. John's University. She received her Master of Arts degree in Mental Health Nursing from Teachers College Columbia University. She was an associate professor at Yale School of Nursing, and she was also the director of graduate program in mental health psychiatric nursing at Yale. She was the project investigator of a National Institute of Mental Health grant, also developed at Yale. Some of the research from the grants at Yale led to the deliberative nursing process published in the Dynamic Nurse-Patient Relationship, Function, Process, and Principles in 1961. She was the director of research projects at McLean Hospital in Belmont, Massachusetts. This led to the publication of the Discipline and Teaching of Nursing Process in 1972, and she served as a board member of the Harvard Community Health Plan. So, in our nursing process theory, it consists of 5 stages, and we're going to break them down, but those 5 stages are assessment, diagnosis, planning, implementation, and evaluation. So in the assessment stage, the nurse will complete a full holistic assessment of needs, both subjective and objective observation, and the nurse will disregard reason of encounter. So the nurse will just pay attention to the way the patient is feeling as well as what she can notice just looking at them. In the diagnostic stage, the nurse will use judgment and infer based on experience she has had over time, taking into consideration risk factors. So in this stage, she'll use all of her knowledge that she has gained from school, as well as just patient-based experiences, and be able to start thinking about what possibly could be causing this patient to feel the way they are, or what they could possibly have. In the planning stage, the stage will have the nurse create a care plan with all gathered evidence. So this is when they will start to break down a couple steps to see how they can make the patient get better. In the implementation stage, the nurse will begin to put the plan in motion, just starting off with step 1 and seeing where it goes. In the evaluation stage, the nurse will look at the progress or lack thereof and change the plan or create a new one. And what I mean by create a new one is if a new problem arises, the nurse can actually create a new plan for that specific problem or diagnosis. So this is a little infographic that we can see. We see that it starts with assessment, and then we're going to move to diagnosis, planning, implementation, and evaluation. And as we spoke of before, if we do evaluation and we see that there's still some issues or we have not resolved our issue, we can go back to the assessment and create the cycle all over again. So some benefits of this theory is that it's universal across different specialties and cases. So if you're in pediatrics or orthopedics, you can go back and forth and use these in different cases to see where it fits best. It focuses on the deliberation and planning, creating a stronger base of plan. So this is going to cause you to be more confident in yourself as well as in your patient, and creating a stronger platform for you to stand on their care. It allows the patient to self-advocate in terms of pain and symptoms. This allows the patient to tell you how they really feel and for you to really listen and take into consideration what those could possibly mean instead of just the facts. It creates a safe environment for both patients and nurses. It's going to create one where the patients feel confident in you and you feel confident in your patient. It also allows for change in the care plan. As we saw in the assessment stage, you can go back and forth depending on how much the patient has progressed or if there's a new issue, and create a new care plan. So some limitations of this theory is that it's not realistic in every case, such as emergency room nursing, which relies on instinct and quick response. This one is very much about deliberation instead of automatically thinking, and it is not best in cases of emergency. So if you have a patient who is in critical care and you need to act within the second to make them better, you don't have the time to sit there and think through all of these things extremely, to sit there and deliberate. You kind of have to use your instincts. And the second point that I put is that some cases are based upon change, waiting to see the patient's developments to create a care plan. Monitoring patients to see how to care for them, specifically in early stages when harder to diagnose. So the reason I put this is that when some patients arrive at the hospital, they do say we need to wait and monitor you to see what's really going on. And that can be part of a care plan, but it's just going to create another change later. So we really didn't see kind of waiting around in this care plan. And so it's not realistic in those cases in the beginning, but later on, this can be used. So how this theory can be applied. Care of patients should be planned and deliberative in any case that you can. In an acute setting especially, these steps can be achieved through triage steps when first entering the hospital. So when you first enter the hospital, you always tell them what you're feeling. They're going to take some vital signs. This can be seen in our first couple steps of our plan, and that's when their care plan begins to be developed. This can be used largely in assisted living or hospice units with elderly patients, creating an end-of-life care plan or rehabilitation care plan. So what I mean by this is that when you're in a long-term care facility, you get to create a care plan for them because you get to see them longer, and it's a lot better for those. And I think that this theory especially would be very strong in assisted living facilities, and especially in hospice units where you're trying to create comfort. And I just think that it would be very beneficial to use in these settings. Nurses may also use this in a school setting when becoming more comfortable with patient care, setting an outline of how to care. So I know that a lot of new grad nurses are very nervous about going into the care setting, and this kind of outlines a way for them to start becoming more comfortable. So my thoughts of the theory is that I believe this theory is a perfect example of patient-oriented care, allowing the patient to self-advocate and be involved in the healing process. It is fluid and malleable, able to be changed to fit certain scenarios, and this theory allows nurses to act deliberately rather than automatically. And what I mean by all of this is that it's very patient-based, and we should be focusing mostly on the patients, and I just think that it makes it such a stronger base for the care plan to be developed. Alright, and the two references that I used for this is the Nursing Theory website about Ida Jean Orlando, as well as a YouTube video titled Nursing Theories Ida Jean Orlando, and it was in 2020 when this was made, and I mostly use this for my infographic I used earlier in the PowerPoint. Thank you so much for watching this, and I hope you enjoyed.